My name is Richard Wong. I am the Chief of the Head and Neck Service at Memorial Sloan Kettering Cancer Center. On behalf of the History Service for the American Head and Neck Society, it is my great privilege today to interview Dr. Jatin P. Shah. Of course, he is an iconic leader in the field of head and neck surgical oncology. He is the Elliott Strong Chair at Memorial Sloan Kettering Cancer Center and has served as the Chief of the Head and Neck Service for over 23 years. He has led virtually every major organization in our specialty and actually was the founder of many of them. He is the past president of the Society of Head and Neck Surgeons, the International Federation of Head and Neck Oncologic Societies, the International Academy of Oral Oncology, the North American Skull-Base Society, and the New York Head and Neck Society, amongst others. He is also the past chair of the AJCC Staging Committee for Head and Neck Cancer and the Joint Council for Advanced Training in Head and Neck Surgery. He has won numerous awards and has written numerous books, including his award-winning Surgical Atlas, Head and Neck Surgery and Oncology. Dr. Shah has published over 500 papers and delivered over 1,000 invited lectures all over the world. He is a surgical master and an educational leader. He has trained a generation of head and neck surgeons, and I am very privileged to be one of his trainees. Dr. Shah, thank you for meeting with me today.
Thank you, Rich, for a very generous introduction.
Dr. Shah, who got you interested in the field of medicine in the very beginning?
It's interesting. In those days, when I was a high school student, Dad knew the best. So we had almost no choice in choosing our career. Father had made the decision for his children, and I was the youngest of the three siblings. And it was my father's wish that his older son become a doctor, his daughter become a housewife and raise a family, and I was destined to be an army officer and an engineer. That was his dictate in those days, and you had no argument. So I was channeled into thinking about an army career in engineering. Turns out that my brother did not do well in biology in college. So he switched his career and went into engineering. And overnight, I was asked to shift my gears to become a surgeon. And my response to my dad was, "Aye, aye, sir." So that's what got me into medicine. In the medical school, I was very intrigued by anatomy. And that led me to surgery as my postgraduate choice. And that's how I became a surgeon.
And then more specifically, Dr. Shah, how did you get interested in head and neck oncology within the field of surgery?
There is also a history behind it. My dad died of lung cancer in Philadelphia. So cancer got me intrigued, and naturally surgical oncology became a choice. There was no internet in those days. There was a green book, which was a published paper-bound directory of training programs, and I looked at training programs in cancer surgery in the United States, and Memorial stood out as #1 program. So I applied for surgical oncology and was selected as a junior resident and subsequently as a fellow in surgical oncology. During these surgical oncology rotations, we had a 6-month rotation, mandatory in head and neck, out of the 2-year fellowship in those days. And that really got me entwined into the complexity of the anatomy, the impact of what we do externally, visually, and functionally to the patient in treating the cancer. And that challenge was enough for me to get involved into head and neck.
Dr. Shah, you've been a mentor to so many trainees and now successful and leaders in head and neck surgery. But can you identify the key mentors for you in the early phases of your career?
So, mentors come in various domains of your career. Early on, while I was learning how to operate, Dr. Manubhai Patel, a senior surgeon back in India, was a master technician. you could put a camera behind his head and you won't have to edit the operation. Such fine technique he had. Every step was a measured step, and I learned technique of surgery from him. And my boss, Dr. A.B. Kothari, was technically not a good surgeon, but he was a master clinician in clinical diagnosis, judgment, analysis of data. That I learned from him. When I came to Memorial, Dr. Elliot Strong was a mentor in etiquette of medicine and doctor-patient relationship. And his was the best I've ever seen anywhere. Dr. Tollefson got me interested in medical photography. And that eventually led to the publication of the books. And Dr. Holland Farr was a visionary. And he wrote me a letter in 1972 when I was a fellow in surgical oncology that, Jay, take up head and neck. One day you will be the chief of this service. I think his was a prophetic assessment of my career at that point in time. So he was a visionary, he was a master clinician, and he was a person who showed you and taught you how to be mature, how to be stable in life. So numerous mentors, but in different domains of the career.
Dr. Shah, you're widely acknowledged as a surgical master, and I'm interested in your perspective on how you teach technical surgical skills. To what degree do you believe that a surgeon's skills are innate versus can be taught and trained? And how has that affected how you have trained your fellows and residents over the years?
Well, some people are born with 5 thumbs, and you can't make them good surgeons. And there are some surgeons who have appropriate use of the 5 fingers, but they need a bit of training. So early on in their careers, when the fellows come into you, within 2 weeks you know whether he is going to be a good surgeon or not. And then you invest your effort in either letting him finish his rotation or make the best use of the time he has with you to ingrain into him every move that you make in the operating table. And you can teach surgery only by having them operate. You can't have them learn surgery by having them see what you do. So it is sometimes difficult to stand at the head of the table and the fellow as the primary operating surgeon. But that is where you point out the right moves and the wrong moves and let him emulate what you would like to do or what you do. And you can see the growth of these people. They grow rapidly. I don't want to single out people's names because it will be unfair to the hundreds of other fellows. But there are some fellows I have trained who could operate on me with their eyes closed. And I will have full confidence they will do the right job.
I think many of your former fellows are very grateful for your attention to detail in their training, Dr. Shah. Can you tell us a little bit about how the practice of head and neck surgery has changed from when you first started practicing to its current practice today?
So it's almost a half a century, I must say, when I got involved into surgery at Memorial. And my entire career, as you know, has been at Memorial, 52 years this year. So the focus of surgery when I started in training at Memorial was on speed of surgery, radicality of surgery, and everything else was secondary. So if you could do a neck dissection in 45 minutes and get out of the operating room, you're a great surgeon. You may have lost 3 units of blood and may have done a lousy operation, but you did it fast. So that was the dictum. The shift came in the performance of surgery was not the speed, but the finesse of surgery, the completeness of surgery, respect to anatomy, respect to tissues, avoidance of injury, undue injury to the tissues. And that is where finer surgical techniques develop. You want to be expeditious, of course, but you want to be meticulous. You want to be bloodless. You want to be conservative in preservation of vital structures and functions, and you should have essentially no blood loss. I would say nearly 90% of head and neck operations do not need blood transfusion.
Dr. Shah, what do you think is some of the current challenges in head and neck surgery and oncology today? And what are the things that we need to be thinking about as we move ahead in the future?
So if you go through the history, I think our specialty is no longer just surgery. In the 1970s, it was head and neck surgery, period. There was nothing more or nothing else. But then came in radiation oncology, then came in medical oncology, then came in targeted therapies, then came in immunotherapy. And along the way came in diagnostic tools, immunohistochemistry in pathology, a mutational landscape assessment of primary tumors to identify appropriate targets to deliver systemic treatments of effectiveness. Along with that came very detailed imaging techniques, CT scans, MRI, PET scan, 3D reconstructions. So all of this technological evolution and biological developments impact upon what we do surgically. So today, our role as surgeons, of course, it will remain at the helm of the ship, but we have many oarsmen without whose help we cannot come out successful in treating our patients. So we need to be conversant of the role of the allied specialties and their importance and effectiveness in developing a multidisciplinary program for each patient, individualized program, to achieve the goal of cure and retention or preservation of form and function.
Dr. Shah, as you mentioned, you spent your entire career at Memorial Sloan Kettering Cancer Center. What do you find so special about this institution?
There is no better place to work. But you can find faults and problems with every institution, and Memorial is no exception. Yes, there are problems and things that can improve here, but there is some virtue in setting your foot at one place and growing there. Take the example of a plant where you put a seed in the ground. You uproot the plant when it is 6 inches tall and plant it somewhere else. New roots have to grow, and the growth is stunted for some time before the plant takes on again. So the American philosophy, if I may use, is to move on from one to other place, and 3 to 4 moves in a surgeon's career is the norm. I don't subscribe to that. I would rather have my roots grow deep in one place and have a tree in my career rather than multiple plants with multiple implantations.
Dr. Shah, what do you think are the biggest challenges in head and neck surgery training currently, and how do you view training from both a domestic and international standpoint?
So the training has become an issue, particularly surgical training, with numerous non-surgical treatment programs evolving, and albeit successful. The surgical volume for ablative surgery has declined. Take, for example, we do far fewer laryngectomies than we did 30 years ago. If we do 20 in a year, total laryngectomies, there are too many. And I remember during the days of my early career on the faculty, 150 laryngectomies was a norm. So that experience is going to go away. We no longer do radical neck dissections. That's going to go away. We no longer do open skull-base surgery for central localized lesions because endonasal skull-base surgery is equally effective. So this surgical experience is going to have to be modulated to form into the new trends in surgical volume and surgical variety. With lesser volume, we are going to have to evolve methods whereby surgeons can learn ex vivo fundamental surgical techniques. And that's where the role of surgical wet labs comes in. That we need to have cadaver labs where fellows can learn how to use an operating microscope and a laser. They can learn how to use a robot. They can learn how to use endoscopic surgery and practice there before they come into the clinical arena, because the volume is low. Even in the best of cancer centers, there is not enough volume to train adequately. And 1 year, in my judgment, is not long enough time to train a good head and neck surgeon, at least in the United States. Internationally, the scenario is even worse, because there are no standard formatted programs with standard curricula. I'm proud to say that the International Federation of Head and Neck Societies has taken that challenge and started off initially with an academic program alone of an online fellowship in head and neck surgery called the Global Online Fellowship, where candidates who are already engaged into surgical practice of head and neck cancer register themselves for a 2-year program where they take quarterly examinations online and have 7 exams over 2 years and have an oral examination at the end of the 2-year program where their judgment and knowledge would be tested. The criticism of that program was that there is no hands-on training. And we have addressed that issue this year. The International Federation has started a comprehensive clinical and academic program where the candidates will do the 2-year online fellowship academic component and will require 1 year of clinical training in an approved center of excellence. And we would be approving centers of excellence around the world. Currently, there are 43 programs around the world who have shown interest in getting approved for this global training. So I think the global scenario will change. It is my hope that in the years to come, we will have one uniform criteria around the world to train the candidates, judge their judgment, judge their skills, and produce a cadre of generations of surgeons who would be uniformly trained around the globe.
It's amazing, Dr. Shah, that this program then can reach people from all sorts of countries with different backgrounds, with limited resources, even places where they don't have centers of head and neck surgery expertise. And I think that's one of the great allures of this program.
Well, the focus of these programs is to train a candidate in his environment, with his resources, with his own staff and support system, but preferably in their own language. It makes no sense to bring somebody from a resource-challenged nation to New York, train him for a year, and send him back to his home institution to work. The poor man will face frustration because he's going to be able to do less than half of what he learned in New York. I would rather train that person at his institution, in his environment, and on his patients with his resources to become a better surgeon.
Dr. Shah, you've long been viewed as a champion for bringing head and neck surgery globally around the world, not just to the trainees, but to existing head and neck surgeons and uniting them. And the creation of IFNOS is really kind of a revolutionary event. Can you describe what inspired you to create IFNOS and what plans you have for IFNOS in the future?
So IFNOS is truly an organization of camaraderie and friendship. It was founded in 1987 at a joint meeting of the British Association of Head and Neck Surgeons and Society of Head and Neck Surgeons joint meeting at the Grosvenor House in London. 16 friends, and I call them friends, from different countries attended this meeting. And that's where IFNOS was founded. Today, it has 65 member societies from 58 countries, literally covering the entire globe. There is no nation or no national organization in head and neck who is not a member of IFNOS. It has programs which cover World Congresses every 4 years, bringing everybody together to review growth and in research and new discoveries and exchange experiences, as well as exchange friendships and camaraderie. It has the Global Online Fellowship, the golf program, the clinical fellowship. It also has the World Tour program, where we took a group of faculty, 6 leaders, surgeons, radiation oncologists, medical oncologists, on site to different countries over a period of 6 weeks, giving 3-day seminars in the past. Thanks to COVID, we could not do it last year, but we did not drop it. We did the seminars in 4 zones virtually, so we are going to now call it Virtual World Tour starting this year. And that will continue to deliver update in our specialty to the audience in various parts of the world at the click of a mouse on their computer.
Dr. Shah, you've made so many different contributions to our field, both surgically and in terms of leadership and in terms of training. As you reflect back, what do you view as your most valuable contribution that you're most proud of to our specialty?
My children, and my children are my fellows. I have 107 children, and all 107 fellows who trained with me make me proud every day of the week that I come to work. And I come to work every day. Many people ask me, have you retired? I said, I'm not tired. Why should I retire? So you are my boss now, and I report to you and to work every day. And every day I get mails and email messages from former fellows. I did this, I achieved this. And their accomplishments and their leadership and their success is my glory. And that's what I dwell on.
Dr. I think I can speak for all of us in saying that we are incredibly indebted to you, and we are incredibly grateful to you for all that you've given to us. So thank you so much. I'd like to finish this by asking you, what words of wisdom would you like to convey to current and future head and neck surgeons, especially our young ones who are just at the early part of their careers?
I will recite the comment of my colleague, Dr. Ronald Spiro, who used to say, engage the brain before you put your hands in gear. So as surgeons, use your brain power first before you put your hands in action. Performing surgery is the ultimate part of the decision process in assuming the responsibility of care of a patient. But to come to that point, there is a lot more that goes preoperatively or pre-decision in your mind, analyzing the problem, the patient, the disease, the stage of the disease, the impact of what you do, the impact of your intervention, be it surgery or non-surgery, on not only on the tumor but on the patient, patient's function, patient's psyche, patient's well-being, and his or her vocation. So I think what I would like to ingrain into future trainees is surgery is a small component of your professional domain. Much more goes on before actual surgery happens in your mind. And that's what is going to drive you or lead you into the decision to operate. And your role doesn't end when you put the last stitch on the skin. That is only end of phase 1 of the responsibility that you have taken to take care of the patient. Your relationship with your patient is a lifelong relationship. It's like your marriage, till death do us part. Because that patient will be with you, coming back to you, fortunately for a follow-up, and hopefully for an annual hello. But some are unfortunate, they'll come with recurrent tumor. And eventually some will die. And you need to be a part of all of these events in the patient's life, because the day you took the patient on, you took a responsibility of lifelong relationship with your patient.
Those are great words of wisdom from an icon in our field, Dr. Jatin P. Shah from Memorial Sloan Kettering Cancer Center. Dr. Shah, on behalf of the American Head and Neck Society, I'd like to thank you for your interview and your time today and for sharing us all of these pearls.
Richard, it's an honor and a privilege to be in the archives of the American Head and Neck Society. The American Society, he has been at my heart, and to the extent that I could, I have tried to support educational activities of the society intellectually, personally, through our trainees, and even in a small fashion financially. But American Society is the strength of American surgery in head and neck cancer. And I hope that current leaders and future leaders will continue to steer the spirit of camaraderie, friendship, leadership, and growth and progress in science as the focus of our society. Thank you very much. I appreciate the honor.
Thank you, Dr. Shah.